Hello, everyone. Very excited to have you all here today in our webinar. And I just want to say thank you to the organizers of the Cord Blood Association for giving us the opportunity to be here today. I'm very excited to have you all. We have a Q&A section later on, so please put your questions there. I'm very excited to be presenting with a colleague, John Coleman from Seattle, and we'll be talking today about cord blood transplant for malignant and non-malignant pediatric disorders. So very excited to have you here today. So as some of you already know me, I'm Carrie Martinez. I'm the chief of the program at Texas Children's and Baylor College of Medicine. And I will be starting. I'll be your host of the webinar, and I'll be discussing the umbilical cord blood transplant for congenital non-malignant disorders. As objectives, we're going to evaluate recent outcomes of these patients. We're going to go over the Texas Children's experience of cord transplant for these non-malignant diseases. We'll include patients with severe combined immune deficiency and other immune regulatory disorders. And then we'll go over the cord blood experience for SCID patients from the PIDTC Primary Immune Deficiency Consortium data. So as you all know, the pediatric non-malignant disorders include patients with bone marrow failure, inherited metabolic disorders, and immune deficiencies. And the outcomes of them is very dependent on the diagnosis that they have, and they range from 40% to 90%. And the major cause of that is either infection, organ failure, or graft-versus-host disease. And the survival really depends on how these patients are doing pre-transplant. You know, they are coming with any type of infection, organ function, and if they have any active disease-related complications. And the major limiting step for these patients is finding a suitable donor. And as you all know, delaying a transplant increases the risk of infection, organ damage, or just progression of the disease. So why use a cord transplant on these patients? Where we know cords are promptly available, they have less stringent HLA matching criteria, they have less graft-versus-host because of the naivety of the cells. However, we know that cord transplant is associated with prolonged period of neutropenia, higher rates of graft failure, and increased infection-related mortality within the first 100 days. So I'm going to take you to the data that we published a few years ago on our experience at Texas Children's. So this is basically the data of a prospective trial that we started in 2008, where we enrolled all pediatric patients that had a congenital or acquired immunological, metabolic, or hematologic disease that were matched at 5 out of 6 at high resolution and DR and low resolution at AFB that had a minimal cell dose of TNC of more than 5E7 per kilo. The platform that we used was a fully ablative regimen consisting of busulfan, cytoxan, and fludarabine. The busulfan was dosed at 16 per kilo, and we did PK levels on this, and we were dosing with an area under the curve between 900 to 1200. As you can see, these patients did not receive any serotherapy. When we started the protocol in 2008, we were one of the pioneers that were removing the serotherapy on this platform and substituting that for fludarabine, which has no effect on the donor T cells that are coming in. The graft-versus-host profile was the usual with CSA and MMF. We enrolled 15 patients that with non-malignant diseases, and transplant were done from 2008 to 2020. As you can see here, most patients had immune deficiency, specifically SCID. About 11 patients of these 37 patients were patients before the newborn screening. So newborn screening in Texas started in 2012, and it was across the U.S. in 2018. So as you can imagine, those patients were a lot sicker when we started. There were other immune deficiencies, some benign hematology patients, and metabolic diseases as well. Most patients were male because of the X-linked SCID. The median age of transplant was 5 months, so very young patients. The matching of them, most of them were mismatched. And the TNC median was 13 E7 per kilo, so basically more than double of what we needed for the protocol. As you can imagine, a lot of these patients had active transplant infections at the time of transplant, and some of these infections were high risk. Like, for example, we took patients that were RSV positive to transplant, parainfluenza, even varicella. Remember that there's a group of patients of this that were done before the newborn screening. So that's what the usual thing that we will encounter during that time. About 40% of the patients had pre-transplant pneumonia, and about 20% required mechanical ventilation before transplant, which make this group of patients of extremely high risk of morbidity and mortality. The median time of neutrophil engraftment for the group was 17 days, and the median time of platelet engraftment was 37 days, with a median donor chimerism at 100 days of 96% and 100 at 1 year. The cumulative incidence of graft versus host 2 to 4 was 16%, and severe graft versus host was 5%, as shown here. And this is even in the setting of removing serotherapy. When we look at the survival for the whole cohort was 91%, with a median follow-up of 7 years. And some of these patients now being transplanted like 14, 15 years ago. When we look specifically at those key patients, as you can see, the survival was in the 90% as well. What was really interesting to see is that a very high number of these patients had engraftment syndrome. Almost 70% of the patients developed engraftment syndrome at a median time of 11 days. And even though these patients had a lot of active infections at the time of transplants, there were a very low incidence of viral disease and actually no viral-related mortality. And this was secondary to a very prompt immune reconstitution, as you can see, that by 6 months after transplant, the CD3 were a median of 1,000, with a very solid above 200 on the compartments of CD4s and CD8s. When you look at the proliferation non-specific on the T cells, more than 75% had normal PHA by day 42. When we look at the humoral compartment, by 6 months, more than 80% of the patients had normalization of IgM production and class switching. So in conclusion of this first part, we saw that there was excellent survival with cord transplant, very early neutrophil and platelet engraftment with very appropriate donor chimerism, low incidence of graft versus host even in the setting of absence of serotherapy, early B and T cell functional recovery with prompt clearance of the viruses. So core blood naive lymphocytes seems to be rapidly responsive and adopt an effector phenotype very early after transplant. So at that point, we were encouraged to use this type of course transplant with no serotherapy for these patients, especially in the ones that had active infection. So then we wanted to see, we had a high number of patients with SCID that received cord transplant and were doing very well. So when we wanted to look, okay, what is the experience at Texas Children's looking at all the SCID over a period of 20 years? And what is unique of our patient population is the amount of underrepresented population that we see here in Texas. And what we know in the North American SCID data is that about 20 to 30% of the patients are Hispanic. And this has been published by the seminal paper of Sun Yu Pai from the Primary Immune Deficiency Consortium in 2014, and then confirmed in the Genheimer paper of 2017. And why we know that is important, as in other diagnoses, Hispanics had a higher increase of mortality on these patients. And that was published not too long ago by Eli Haddad. So as you know, we only find 20% of our patients will have a match-related donor. So we will need to go to the registry. And as expected, all of these minorities will be underrepresented. So if you look on the Hispanic cohort, if you want an ideal donor, less than 35 years old, the probability of finding a donor for a Hispanic is less than 40%, and even lower in the other minorities, allowing us then to look at what is available as an alternative donor source, either a mismatch or a haplo or a core unit. So then we wanted to look at overall survival and event-free survival on this cohort and then compare the outcomes among them. So we enroll in this retrospective review 67 patients transplanted over a period of almost 20 years. We define event-free survival as survival in 360 days after transplant without any need of additional transplant, top-off, or donor lymphocyte infusion. And immunoglobulin therapy independence was defined as the date of the last infusion post-transplant. As you can see, we had most of the patients were male, as expected, and about 60% of the patients were Hispanic. Most patients require one transplant, but 7 patients did 2 or more. And the median age of transplant was 5 months, which expected, as we saw in the other data. About 70% of the patients were minority, with almost 60% being Hispanics, like I showed. So that definitely put us in a place that we needed to use alternative donor sources. As you can see here, most of the patients receive a cord transplant. This is very common on our patient population and our center here in Houston, and it's mainly because of the demographics of the patient population we see. When we look at the genotypes, most of the babies were IL-2RG, that's the most common, but it's interesting that we saw a good amount of patients with leaky skin, RAG1 and RAG2, and an increased a number of IL-7 receptor, which we think perhaps we're looking into this more, that it seems to be more common in Hispanics. Most of the patients receive a myeloablative regimen, as seen here, with a backbone in busulfan. And the 5-year overall survival of the whole group was 83%, and with no difference by donor type. It's important, and I wanted just to clarify, this curve is showing the related donors with a very poor survival. I want to say that these patients, because this is not what you're going to see out there, these patients were patients done before newborn screening, and we had a couple of patients that were almost adult ADA patients that were in enzyme replacement, so very high risk patients. But the most important thing I want to point out is that there was no difference among the donor types, and the course actually had an excellent survival among the group. Which was really reassuring for us to see was that actually Hispanic have better survival than non-Hispanic. At least we wanted to know that they didn't have worse outcomes like it was reported earlier by PIDTC data. The event-free survival of the group was 74%. And when we look at event-free survival by donor source, it was strikingly better in patients that received a cord blood graft. When we look at the cumulative incidence of independence of IVIG, as you see here, also was much better in the cord blood graft compared to the other donors. And it was really good to see that even in the setting of not doing cell therapy on these patients, we did not see any difference in the incidence of graft-versus-host. So in conclusion for this part, we see that this cohort had excellent survival for kids, that the overall survival and the EFS was improving in Hispanic, and that it seems that the EFS is higher in patients treated with a cord transplant, and definitely they have a significantly shorter time to IVIG independence, offering a very good alternative, stem cell source for kids that do not have a match-related sibling. I want to point out that most of those haplos that were done here in our center were CD34 selected haplos, which is different to what is done right now. I'm going to take you through a small group of patients that have very challenging immune deficiencies. And this was presented in ASTCT this past a few weeks ago. So we wanted to look at all the patients that have immune regulatory disorders over the last 20 years. And as you can see here, I mean, these are patients that have very rare mutations. About 90% of them had a mutation. So they are very extremely rare, as you can see. And these patients come with immune deficiency, but also many other organs involved secondary to inflammation or autoimmunity. And as you can see, the median comorbidity index was 3 for the whole group, making this group of patients extremely with increased morbidity before transplant. As the usual that I've been showing, again, about 70% of our patients are minority, about 50% of those were Hispanic, making us needing to go to the alternative donor source route. And on this group of patients, we have 30% of them receiving a cord. Most of them receive a myeloablative regimen, which is very common on the immune regulatory disorders because of the high risk of having a rejection. The cumulative incidence of neutrophil engraftment for this group was at day 42 was 96% with a median time of 16 days. And the cumulative incidence of engraftment syndrome was 35%. And when we look the cumulative incidence of engraftment syndrome by donor type, not surprisingly, based on the data we have seen, the cohort's transplant had a higher incidence of engraftment syndrome compared to the other donor sources. Then we look and see if the serotherapy used, yes or no, affected on that engraftment syndrome. And not surprisingly, if you receive serotherapy, the chances of having engraftment syndrome are less, and even much less if you're using alemtuzumab. The overall survival for this group at 2 and 5 years was in the high 70s with a median follow-up of 6 years. And it was really reassuring to see, again, no difference on the Hispanic versus non-Hispanic. And then there was no difference across all the donor sources. But what is interesting is that the cord blood transplant are approaching 80% survival on this very high-risk patient population. Of course, with the related donors being in the 90%. The incidence for graft versus host was 34%. And when we look at the difference by donor type, it was also very reassuring to see that the incidence of graft versus host in the setting of courts was only 30%. So compared to the other sources that we saw an increased rate of graft versus host. When we look at graft versus host by serotherapy, there actually was no statistical significance. And I am thinking, because this goes contrary to what we all know, I think it's because of the high number of courts that we have on this group of patients. And then I'm going to take you, because we wanted to see, okay, this is our data here. Let's see what is happening in North America. So there's a manuscript in preparation. We presented this at ASTCT a couple years ago. And we wanted to see how all the cohorts for SCIDs are doing in North America as part of the primary immune deficiency treatment consortium. So we basically look at the studies of 6901, 6902 of the PIDTC. We had 130 patients transplanted in a period of about 20 years. And then we look at the usual transplant outcomes. And I'm going to walk you through what we found. So we had 130 babies. 60% of them were males. And as you can see, and I showed you that before, the Hispanic distribution was 30%. And the median age of transplant was about 6 months. Remember that there's a lot of these patients that were done before newborn screening. Most of the cohorts were mismatched. And as different to us in our center, half and half of these patients received a myeloablative versus a reduced intensity conditioning. There were still a group of patients that received only immunosuppression or no therapy at all. This group of patients that did not receive anything were patients that were sicker than the other patients as expected. Most of the backbone of the myeloablative and the reduced intensity was done with busulfan. Contrary to our institution, most patients receive ATG, with about 30% of the patients not receiving any serotherapy. The overall survival for this group was 76%. But when we look at more recent data, which this goes along with the data we're seeing in transplant, the 2-year overall survival was 82% in the most recent decade. When we look at overall survival according to conditioning, patients that got a myeloablative regimen did better than patients that did not. I want to point out that this group of patients in the non or IS seem to be sicker, and probably making the transplanter not able to give intensity or chemo to these patients. So for further analysis, we removed this group and analyzed the ones that were conditioned. When we look at the most recent era and we compare MAC versus RIC, there seems to be a trend for better overall survival, even 93% on these patients when they receive a myeloablative regimen. Then we wanted to look at overall survival according to serotherapy. And when we look at all of them, we didn't see a difference. Remember, that still contains those patients that were sicker, that did not receive chemotherapy. But when we look at the MAC and RIC only, the 2-year overall survival seemed to be better on patients that did not receive serotherapy compared to the ones that received serotherapy. The 2-year cumulative incidence of subsequent treatment was only 8%, so only 10 patients required additional therapy. There was no difference on conditioning. And what seems to be very interesting is that the patients that did not receive serotherapy had no indication for doing a second transplant or any type of intervention afterwards. And this is not statistically significant, but seems to be a strong trend. When we look at EFS, and events were defined as death or subsequent treatment for the whole group was 72%. When we look at the most recent era, there seemed to be an improvement of the most recent era compared to the prior decade. When we look by conditioning, the patients that get myeloablation have better EFS compared to the patients that are not. Again, this is including that group. When we take away that group and look only at the condition on the most recent era, which is the era that we know that is doing better, the patients that receive myeloablation have a better 2-year event-free survival compared to the ones that receive a reduced intensity. When we looked at an EFS by serotherapy, there seems, when you put them all together, there seems to be a trend for better EFS on patients that did not receive serotherapy. But what was strikingly significant is patients that receive conditioning regimen and no serotherapy have a 5-year event-free survival of 91%. The cumulative incidence of the group was 20% all comers and severe graft versus 6%. Chronic graft versus was 22% with moderate at 11%. When we look at cumulative incidence of graft versus host, according to conditioning, there was no difference. And when we look by serotherapy, something super interesting that we're still trying to understand, patients that did not receive serotherapy did a lot better, and this was strongly significant compared to patients that received serotherapy. This went along. We wanted to see how was the difference on patients received serotherapy versus not on their immune reconstitution. And what we saw was the same thing that we are seeing at TCH. So patients that did not receive serotherapy had a more prompt immune reconstitution in all the T cell compartments, as you can see here. As expected, there was no difference on the B cell compartment. So the take-home message from all of this, basically, cohort is an acceptable option for patients with non-malignant disorders and could be perhaps preferred on patients that have SCID or immune regulatory disorders when you don't have a matched sibling donor available. And conditioning without serotherapy is preferred, especially in the setting of infections, because of the prone immune reconstitution, as we showed. Cord blood transplant conditioned without serotherapy provides a solid engraftment with very early immune reconstitution. And it seems to be a very appropriate option, even in the setting of minorities, including Hispanics. And that those disparities in survival outcomes in patients with SCID could be overcome using a platform like this with a cord blood transplant conditioned without serotherapy. And of course, none of this will be possible without all the help of all my mentors, my whole clinical team, and the nursing leadership, of course, the group from the PIDTC, and all my immunology colleagues, and all the BMC staff, the nursing, the APP team, and the fellows. But honestly, most importantly, the whole reason why we're here, our patients and families. Thank you all for your attention, and I'm going to pass it along to John for his malignant talk. Please put your questions in the Q&A, and we'll address it later.
Thank you, Kerry, for that introduction and for that really lovely presentation with some wonderful data. I think that was really interesting for everyone involved today. So give me 1 second to bring up my slides. Here we go. So it's a pleasure to be here speaking to everybody today, and thank you for the invitation to this webinar. So as Carrie said, my name's Dr. John Colgan, and I'm currently the BMT Fellow at Seattle Children's Hospital and Fred Hutchinson Cancer Centre. And today I'll be looking at the other side of the coin, so discussing the role of cord blood transplantation in malignant diseases. And so I wanted to just begin today's talk by outlining the key question I hope to address during our time here today, and that's what's the role of cord blood transplant for children and young adults as well with malignant disorders in 2025 and beyond. And I'll be exploring that through the lens of a clinical trial which was recently completed at Fred Hutchinson Cancer Centre, focusing on the objectives and takeaways from that trial, which I think really helped to shine a light on where cord blood is most useful for patients with malignancies, both now and in the future. So cord blood is still considered by many to be an alternative donor source. But as you'll come to see during my presentation today, I think we would like to start the argument that it's more than that, and it really should be considered on its own merits. And whilst almost all of this is known to those of you in the audience, and I know that Carrie's covered this a little bit as well, let's quickly review the importance of alternative donors for transplantation. So matched sibling donors remain the first donor choice in many centres, especially in the case of malignant disorders, but only around 30% of patients will actually have a matched sibling donor available. Most search algorithms then would pivot to a matched unrelated donor, and this study from the New England Journal of Medicine in 2014 shows the availability of 8 out of 8 matched unrelated donors for different racial and ethnic groups. Whilst Anglo-Europeans have approximately a 75% chance of finding an unrelated donor, the donor pool for other groups is much lower. You can see that African Americans, South and Central Americans, and those of Caribbean ancestry had a less than 20% chance of finding a matched unrelated donor when this study was published in 2014, and updated data is very similar. Even when a mismatched unrelated donor was considered, defined as a 7 out of 8, over a quarter of some of these groups can still not find a donor. Fortunately, over the last decade or so, significant advancements have been made in cord blood transplantation and more recently haploidentical transplant. And when a 4 out of 6 or greater matched cord blood unit is considered, 95% or more of all patients have a cord blood donor. When this is added to a similar estimation that 95% of patients have haplodonors available, we're now fortunately in a position in the 21st century where essentially all patients will be able to find a suitable donor. But we would argue, as I said, that cord blood is more than just an alternative donor source for those with malignant diseases. Cord blood has a number of really well-known and unique advantages, and that's something this group would be well aware of. But things like improved time to transplant, reduced rates of chronic graft versus host disease, and low rates of transmissible infection. And I think it's important to say at this point that there are many studies that show equivalent outcomes between cord blood transplantation and conventional donor transplant, both in the malignant space and, as Carrie just really nicely presented, in the non-malignant space too. One of the most exciting benefits, which is newly identified in cord blood transplant, is this concept that cord blood has demonstrated a really distinctive and profound graft versus leukemia effect when it's compared to other stem cell sources. And that's been most noticed in the acute leukemia cohort and in those with minimal residual disease. And this has been shown in 2 really landmark recent retrospective papers. The first by Dr. Filippo Milano and our extended cord blood group here at the Hutch, who showed improved survival for those with residual MRD in the acute leukemia cohort for both adults and children. And the next by Claire Horgan, Rob Wynn, and the UK cord blood group, who demonstrated reduced rates of relapse in pediatric AML patients with MRD receiving cord blood transplant. Here is a bit of a deeper look at some of the data in the UK cord blood group paper. As you can see on the left, there's improved cumulative incidence of relapse for both the MRD positive and MRD negative patients who received cord blood transplants, with a favourable relapse rate in the MRD positive group in particular. And this remains evident in MRD positive event-free survival. However, there was no significance for the MRD negative population seen, and that's likely due to an increase in NRM in the cord blood group. And that's something that we'll be tackling today as well. Analysis past 2 years can be a little bit difficult given follow-up, but those curves seem to flatten out by that point. So an important question is, what's holding cord blood back from being considered on the basis of its merits rather than some of its historical shortcomings? Well, I think there's been some concern that this enhanced GVL effect that has been demonstrated recently has never been demonstrated in a prospective fashion. And that's something that we really sought to address and we'll talk about today. Secondly, I think a huge part of the problem is that there's a perceived bias or misinformation about the outcomes and difficulties in performing cord blood transplantation, despite clinical evidence to the contrary, as evidenced through ongoing concerns about things like rate of infection and time to engraftment, when supportive care has really progressed to a point where these concerns have been allayed to a large degree. More data on the long-term benefits, things like lower rates of chronic GVHD and faster time to coming off immunosuppression, will also be extremely helpful. And finally, whilst evidence really clearly shows that myeloablative conditioning improves survival in cord blood when compared to reduced intensity conditioning, those improved relapse rates which were demonstrated above haven't really translated into meaningful improvements in overall survival over time as yet. That's demonstrated here in an extract from that UK cord blood group paper I've discussed. But it's important to note that the overall survival data from both this study and others is looking at transplant over the last 1 to 2 decades, and much of it is retrospective in nature. But when we examine the historical data for cord blood transplant, one of the main contributors for these survival concerns is thought to be high rates of non-relapse mortality in a select cohort of cord blood recipients. And one alternative to improve survival in this group is to utilize an intermediate intensity but still myeloablative conditioning regimen to be used in a very carefully selected group of cord blood recipients who carry with them quite a high risk of transplant-related toxicity, and that's usually due to the presence of pre-existing comorbidities. Indeed, Dr. Juliet Barker and the cord blood group at Memorial Sloan Kettering developed one such regimen and published on its use in adults in 2020. The figure on the right in this slide is taken from that publication, and it shows really promising survival rates in a cohort of around 90 adult double cord blood transplant recipients who were conditioned with this regimen. Let me go back for 1 second. Another benefit of this intermediate intensity regimen is that these traditionally utilize a low dose TBI, defined as between 200 and 450 centigrade. And that's usually been associated with reduced rates of secondary malignancies and other things like long-term metabolic complications when compared to traditional high dose TBI containing regimen. And that's been confirmed in recent long-term follow-up work by Scott Baker. This is particularly appealing in the pediatric AML population or in infants with ALL particularly. So with all this in mind, we designed a prospective single-arm phase 2 trial for adults and children undergoing allogenic cord blood transplantation after myeloablative conditioning for the treatment of malignant disorders. Now, in this trial, we offered 2 regimens, and these were selected based on physician preference, taking into account things like comorbidities in particular and disease control. The first was, of course, the traditional high-intensity myeloablative regimen consisting of fludarabine, cyclophosphamide at 120 per kilo, and 13.2 gray of TBI, which is the standard of care conditioning for cord blood transplant in our Centre for Malignant Disorders. The alternative regimen was the previously described intermediate intensity regimen, which included fludarabine, cyclophosphamide at 50 per kilo, thiatepa, and 4 gray of fractionated TBI. And this so-called regimen B was added midway through the study, and so as you'll come to see when we discuss the results, the number of patients who received this regimen was smaller. Immunosuppression was a combination of cyclosporin and MMF, and that's standard of care at our institute. The primary endpoints of this study were the primary endpoint was overall survival at 1 year, and the secondary endpoints focused on expected outcomes, things like TRM, engraftment, relapse, GVHD, and importantly, clinically significant infections. Now, eligibility criteria were standard for a trial of this nature. In terms of inclusion criteria, just to highlight, not particularly relevant for the pediatric angle of this talk, but the age limit for the middle dose TBI regimen was 65, so that's 20 years higher than that of the high intensity regimen. And the appetite to offer TBI to an older population was another important reason behind offering this option. Quite a wide array of malignant disorders were accepted for this trial, as you can see, but as you'll come to note when we look at the characteristics, the vast majority of patients enrolled were those with either acute leukemia or MDS. In terms of unit selection, cord blood units were matched out of 6 based on HLAs A, B, and DRB1, and that's standard practice at the Hutch. And as a minimum requirement, they needed to be 4 out of 6 matched based on intermediate res typing at A and B and high res typing at DRB1. The preference was to infuse a single cord blood product if available. However, to do so required the selected unit to meet specified T and C dose requirements, which are demonstrated in the table to the right of the slide, whilst also meeting the requirement for a CD34 cell dose of 2 by 10 to the 5. Otherwise, 2 cord blood units were used. So beginning our results with patient characteristics. So there were 132 patients who were enrolled in this trial. The median age was 20, and the median follow-up was 3.5 years. The most common indication for transplant, as I said, was acute leukemia or MDS, and that group made up 86% of our total cohort. We've included information here on status at the time of transplant, really just to indicate that this study examined quite a high-risk population, and that's important to take into account when we look at the outcomes. with around 30% of patients MRD positive and 30% in CR2 or higher at the time of transplant. 40% of patients received a single cord blood unit, and there was a fairly even split between the pediatric and the adult patients on this study, with the pediatric cohort being defined as 21 years of age or younger. Only 20% of patients received this intermediate intensity arm, and again, that's a factor of it being introduced midway through the trial. Acute GVHD rates were consistent with existing literature, with grade 3 to 4 occurring in around 20% of patients, and that cohort skewing to the adult group. Median time to neutrophil engraftment was 21 days. And I think when we combine that data with Carrie's excellent neutrophil engraftment in the study she's presented, I think it's a really important result and represents the fact that better unit selection and utilization of things like colony stimulating factor have allayed previous concerns in cord blood about delayed time to neutrophil engraftment. Importantly, time to engraftment for both neutrophils and platelets did not differ between the two arms of the study. There were 3 patients on study who experienced primary graft failure. However, all of these were salvaged with a second graft. So now on to outcomes. So as you can see, when you take the whole cohort, outcomes for patients enrolled in this trial were excellent, with clearly sustained overall and progression-free survival, coupled with low rates of relapse and NRM in both the pediatric and the adult cohorts. And these are results which I think it's fair to say compared favorably to historical comparators. In the whole cohort, 2-year overall survival was around 75%, 2-year PFS was 70%, 2-year relapse rates was 16%, and 2-year NRM was 14%. In the pediatric cohort, a bit more of a focus for today, the 2-year overall survival was a fantastic 81%, PFS very close at 78%, relapse rates of 13%, and NRM of 9%. These results were mirrored when we examined the acute leukemia cohort specifically, again, likely as a function of patient distribution on the study, with again, low rates of relapse and low rates of NRM here being striking when compared to historical cord blood data in particular. I draw your attention here to the high rates of progression-free survival in the pediatric cohort, again of around 80%, especially impressive when we consider the high-risk nature of this cohort that I've outlined. But moving on, we really wanted to drill down further and examine those 2 core tenets that I raised at the beginning of this talk. The first, as evidenced in this slide, is that this study confirms the unique GVL effect that we see in cord blood transplant. Those with MRD had exceptionally low rates of relapse, with a 2-year relapse rate amazingly of only 11%. And this was supported by a non-significant hazard ratio for relapse when compared to MRD negative patients, which I think is a hugely telling outcome. This validates prospectively what our group demonstrated in our prior retrospective analysis in 2016. Now, hazard ratios indicate that those with residual MRD do still have a higher NRM and a worse overall survival than those without MRD. And the presumption here is that this is a result of more intensified therapy prior to transplant, with the goal of attaining a molecular remission, something which I think adds further impetus for us to pursue that intermediate intensity conditioning strategy for a select group. When we looked at the pediatric specific cohort for this GVL data, the numbers were even more striking. Now, numbers were admittedly small, but there was absolutely no signal of difference between the 2 groups, with really strong outcomes in the MRD positive pediatric cohort. I again draw your attention here to an overall survival rate of 91%, which I think is incredibly impressive, a PFS of 82%, NRM of only 9% in that group, and hazard ratios demonstrate absolutely no difference between MRD negative and MRD positive patients, this time in any of the outcomes assessed, including NRM and overall survival. So now on to our second key point, the utilization of a middle intensity myeloablative conditioning regimen. Again, this intervention demonstrated pretty remarkable efficacy, particularly in children. So firstly, when we're looking at the acute leukemia cohort altogether, the results are remarkably similar to the whole acute leukemia cohort, with an overall survival rate of around 66% and a PFS of around 60%. And secondly, when we look at the pediatric cohort specifically, all patients in this group were treated for acute leukemia, or MDS, it's important to say. And as you can see clearly, there were low rates of NRM at only 11%, without a really substantial increase in the rates of relapse. And I think that truly represents the utility of this regimen within the group. Hazard ratios for failure, which are not pictured in this slide, also represented no difference in outcomes between those who received the intermediate or high intensity regimens in the whole cohort and all relevant subgroups, including the pediatric group, although admittedly numbers were small. The opportunity to de-intensify therapy in certain patients, I think, is really critical. And this represents the first time that an intermediate intensity conditioning regimen has been investigated in a pediatric cohort. And these early results are really promising. So in conclusion, data from this prospective trial demonstrates excellent outcomes for cord blood transplant recipients receiving myeloablative conditioning in both the high and the medium intensity arms, with particularly positive outcomes noted in the pediatric cohort. We currently have a cord blood network protocol open, which is a companion protocol with other centres, and we're aiming to reproduce this data with increased numbers and in a multi-centre setting. Critically, this study confirms prospectively that in contrast to other stem cell sources, cord blood demonstrates low rates of relapse in acute leukemia patients with MRD coming into transplant. And that's consistent with evolving literature in the field that I've discussed. And overall, I think this study highlights the role of cord blood as a really uniquely beneficial donor source in transplant for malignant patients. So how do we stratify our graft choices for malignant patients here at the Hutch, both now and then, as we'll talk about on the next slide, in the future? So matched sibling donors really are still the gold standard, and our traditional position has been to utilize a matched related donor for first transplants, even when the patient carries with them a high risk of relapse in the setting of aggressive or persistent disease. When a matched sibling is not available, our next step would be to consider both matched unrelated donors and cords as a graft source. We have tended to look to matched unrelated donors first. However, there are certainly times when we use a cord blood unit over a matched unrelated donor in situations like a short time to transplant, very young patients, or in an evolving fashion, those with residual disease. We preferentially perform cords over haplos at our centre. I think it's important to say, due to our excellent outcomes and our experience with doing cord blood transplants. It's important to note that we're very comfortable doing this at our centre, and almost 50% of our allos are cords in pediatrics. This is part of the problem, I think, for programs that are just starting, in that it can be difficult to develop experience unless it's a graft source that you're committed to utilising in the long term. So what does all this mean for cord blood transplant in 2025 and beyond? Well, first, I do think that this data changes the algorithm for the use of cord blood. And I think we should move away from a one-size-fits-all mantra when it comes to graft sources and consider individual patient disease and risk factors in donor decision-making. In the case of cord blood transplantation, a patient's MRD status and their risk of relapse should really be one of the most important considerations when we're choosing a graft. And the data we've presented suggests that any patient who has residual disease at the time of transplant or who is receiving a second allogeneic transplant after another relapse post their first should be at very least consider a cord as first-line choice. Additionally, one way that we can continue to improve cord blood transplant in the future is by further enhancing GVL, a field which has seen significant advancements over the past few years. Whilst there is no DLI opportunity with cords, there are other ways that we can enhance GVL through things like cellular therapy, graft manipulation, as well as post-transplant maintenance therapies. And there have been a number of recent examples of this either published or presented at international meetings over the past 2 years. So I'll draw your attention to a couple of case studies. The first, dilanubicil, a cryopreserved non-HLA matched expanded progenitor cell product, which is also made from pooled cord blood units, essentially generating a cellular immunotherapy. And administration just after cell infusion leads to a lymphocyte burst and enhanced GVL effect from the cord blood unit. And Dr. Milano presented a lovely abstract at ASH, which demonstrated remarkably low rates of relapse when given at the time of transplant. There's also been a recent publication on granulocyte transfusion during cord blood transplant in the setting of relapse or refractory AML. And this publication noted that it's associated with a massive CD8 T cell expansion, significant cytokine release, and induction of disease remission. And then finally presented by Dr. Wynn at ASH in 2024, data on leveraging HLA with winning and losing units in double cord transplant, whereby if the losing unit and recipient share the same HLA mismatch with the winning unit, that same T cell response that mediates rejection of the losing unit will also be directed at the leukemic clone, thus reducing rates of relapse. All novel ideas with demonstrated efficacy in pilot studies that could be expanded with the right support. It's 2025 and there's a donor for all. We need to move to patient-specific donor selection based on underlying disease and comorbidities. We certainly have enough data on the pros and cons of various donor sources at this time to make that move. And so with that, I'll finish up. I'd like to acknowledge the wider cord blood group here at the Hutch for their tireless work on this project I presented for the better part of the last decade, as well as others. Special thanks must go to Doctors Anne Dahlberg, Colleen Delaney, and Filippo Milano, who are the senior investigators as part of this trial and really the driving force behind it. Special thanks also to Dr. Ted Gooley, who provided really wonderful statistical analysis for both this presentation and the pending manuscript. And with that, I'll finish up.
Thank you, John. That was amazing data. I couldn't have said it better. I agree. We're in 2025 and we need to start considering the appropriate donor for each patient, patient-driven, right? I have, maybe we can go through some of the questions. I want to remind everyone, if you have any questions, please put it in the chat or in the Q&A. Maybe since you just presented, John, I'm going to, there's a question here for you. Were you able to separate out the AML versus ALL patients when looking at relapse rate and overall survival? We know that AML patients have higher rates of relapse post-transplant, so I was wondering what proportion of the acute leukemia group was made up of AML specifically?
Yeah, so I don't actually have the numbers off the top of my head, I apologize. And that's an analysis that we haven't completed yet. But looking at the initial data that we have, it looks like there was a fairly robust cohort of both ALL and AML patients who came into transplant with minimal residual disease. And it looks like the rates of, it looks like when you compare the two cohorts post-transplant, there's no signal of difference. And so it seems like cord blood transplant are efficacious at reducing rates of relapse for both ALL and AML when you come into transplant with minimal residual disease.
That's awesome. Thank you. There's another question asking about the role of cord expanded unit for pediatric patients. At our way of managing here is, we look for a single cord mainly, and in the non-malignant field, we try to stay with a very conservative dose. And for the patients I do, most of the time you have a very young recipient, so we don't necessarily explore that route, but perhaps it's something that in the immune deficiency setting, we would love to have, that alternative on patients that are older. We get patients with peer immune regulatory disorders that we don't have a unit, and doing a double cord would be more aggressive, and as you can expect, the non-relapse mortality, the relapse mortality TRM is going to be higher on that group. So, but I don't know if you can mention a little bit on your data, John, regarding this question.
Yeah, we kind of moved away here from expanded cord blood units. That was something that we were pursuing, a decade ago, and that's, I think, where the initial data from the dilanubicil product actually came from, ironically enough. However, I think when you consider the really excellent engraftment data that we both presented, and I think the fact that we haven't seen a difference in outcomes for single versus blood transplants, at least in the pediatric cohort, I don't think that we're pursuing at the moment expanded cord blood units. And really what we're focusing on when it comes to graft manipulation and additional products is sort of trying to really augment that GVL effect that we see when we use products like dilanubicil.
Yeah, totally. There's just a recent question brought up. How do you identify and proactively collect sibling cord blood, hopefully manage? That is a very good question. In the non-malignant field, if we have a congenital disorder, that is definitely something that we explore and we do. Of course, I had patients that the patient needs to proceed right away. So and the mother is pregnant, so we can't wait. But we certainly help store that cord if anything is needed. So I think that to me is very important, and we definitely address it when we see these patients. I don't know if you have encountered that, John.
No, not as much in the malignant space, but I would say I would agree. That's similar to what we would do here.
Great. Let me see if I don't want to miss any questions. This is an interesting one. Is there any data studies that evaluate the age of the cord blood unit at transplant in relation to how well the ANC and platelet time to engraftment is affected? For example, is there any delay in engraftment in older cord blood units used for transplant? At least in the non-malignant, I think it's a great question. And I have not looked personally at our data. Our engraftment and neutrophil and platelet recovery was very early. I think it's because of the nature of how small our recipients are. But I wonder if you guys in Seattle do anything with the age of the unit, John.
Not necessarily. I think I don't think that certainly there's no data in the clinical trial that we've got that looking at that, and I don't believe that it's something we could pull out. I think we've had fairly good results here about our post-thaw viability, and so in terms of the age of the unit, we haven't seen a signal of difference. But again, it's not something that I've got data for that I could confidently talk to.
Mm-hmm. Thank you. In the field, we try to, if you have both options, then you go with a more recent cord, but you're right. I think if you don't have a cord, we will use. We know that the cells are very viable. With your data showing good time to hematopoietic recovery and excellent overall survival, what are the next steps? And what do you see as the main issues we still need to overcome in graft versus host disease? Now, there's some patients who are still not going to transplant, and why? Is there any role for the new expansion technologies? I think we discussed about the expansion. I think the main question probably for you and I, John, is what is next? I think in the cord blood field, we are passionate about this, and that's why we're bringing this to the community. It's definitely a donor option that has a lot of benefits, and we need to try to make sure that we educate everyone out there that this is an option that should be considered, right? I think the outcomes that we're seeing are excellent, and for some of these diseases, many times if you don't have a sibling donor, could be the best option, right? So to me, what is next? I think one of the things that we're working here at TCH is to show, long-term survival. What I can see in the SCID patients following them in our long-term survivorship clinic is patients that receive a cord has extremely good engraftment of all the compartments on the lymphocytes, which is a problem on patients with SCIDs. So I'm working on publishing that data on the long term, because I think that definitely is going to show a significant difference on patients that are transplanted with other donor sources, at least on the SCID population. So I think those are things that we definitely need to get out. As far as other issues to overcome, I think what you were presenting of the non-relapse mortality, the TRM, endothelial injury situation, I think those things we need to look further and see how we can improve it. We see a lot of engraftment syndrome, and in midway through the protocol, we realized that patients were all getting treated with steroids, and thankfully they were all responding to it, right? So now what we do at TCH is we put the steroids prophylactically at day 5. And what we have seen is that these patients are not getting as sick as they were getting when we started the trial. So I think, is there any other way that we can prevent even that? We're looking out at cytokines and see what is happening early on this graft, that perhaps we can even prevent anything, because I think that even though that engraftment syndrome is less strong as what it used to be, and it's a lot more manageable now that we're doing the steroid prophy, perhaps, that's causing a little bit of endothelial injury that we could prevent. And so I think that's a great question that we're trying to answer. I don't know if you have encountered anything like that, John.
Yeah, I think, I'd very much agree with your point on the long-term outcomes. I think that it's desperately needed for us to have more robust data on the long-term outcomes for cord blood transplant. I think the numbers are there and the follow-up data is there. I think it's just something that we need to pursue, because I do think that, if we're able, I think it's all about education and getting the message out there about the long and short-term benefits. And, if we're able to show such an improved rate of chronic graft versus host disease, which I think would be such a benefit for patients as they move into their adulthood, and that's the signal that I expect to see. Certainly data that we've analyzed from back in my home country of Australia showed significantly reduced rates of chronic graft versus host disease in the intermediate to long-term follow-up. I think that would be really helpful. And then in terms of what's next, I think I covered a lot of that in the last couple of slides. For me, I think it's about getting the message out there about the benefits. It's about being a little bit more careful and thoughtful about what grafts we choose, and then continuing to work at coming up with novel ideas to augment graft versus leukemia effect in the malignant cohort.
Yeah, totally agree. In the era that we're living now, that is either haplo versus cord, and cohorts are moving away, I think is very important, and we are responsible of keeping these donors alive. Certainly there is an issue when you have minorities and representation in the registry, and these outcomes are very encouraging, and I want to make sure that people see, and that's one of the main reasons why we brought these topics today to you all. So thank you for that. Let me see. There's a few things more here. I just want to. We have a few more minutes. So, is a single course sufficient enough for older kids patients? How often are the cells insufficient with single cohort?
So I think, I mean, I can take that one just from our experience. I would say that it's probably about a 50-50 split, but there is probably a higher rate of single cord use in older patients than what people might expect. Just as an anecdotal evidence, I've got a 21-year-old who's going to transplant in 2 weeks' time that we're caring for, who's getting a very robust single cord unit. So I do think that, yes, there will be some in terms of HLA matching and size. There'll be no choice but to use 2 cords. But we've actually had quite a good hit rate of finding large single cord units for our older adolescent or young adult donors. And we've seen that the rates of engraftment are not significantly different, or the time to engraftment, I should say, is not significantly different.
That's great. John, what about if you meet criteria of your TNC, but you're not meeting criteria on a patient that is a bigger recipient, not meeting criteria for the CD34s?
Yeah, we'll still go with I think both of those are really important. And what we've done there in that situation is still use 2 cord blood units if the CD34 dose is not high enough.
Got it. Usually, because the patients that I transplant are much younger, we don't get into that issue often. There's a very good, interesting question here about the cost. Should cost of cord transplant still be an issue of concern? I think that is a very good question. I don't know, in adult medicine, in peds, we don't get that issue often. I think with all the new therapies coming in so many other areas, I think these things are important, but it has not been an issue, at least here at our center. When you compare the other type of platforms, like, an alpha beta depletion haplo, for example, that is definitely require a lot more resources than a cord blood unit. I don't know if you have any insight on that, John, as far as what your center do or think.
No, I mean, we're similar. We're a pediatric center, so we really don't get too caught up in the cost of cord blood. But I would just say, cost is, it's obviously a haploidentical transplant is cheaper with PT-Cy, but I think you've really got to consider the way the pros and cons. And I think that there are enough really unique benefits to giving a cord blood transplant, certainly in the malignant cohort, that I think the benefits really outweigh the cost of the increased cost that might come from using a cord.
With this data be presented at EVNT or in upcoming conferences, we just presented it in ASTCT. I think you presented yours recently, right, John?
Yes, likewise.
And we are working on the manuscript to hopefully send this out there so it's available for everyone. Are you publishing the data comparing cords versus haplo? Yes, we're definitely working on that. I'm hoping to submit this data, both of the stuff I presented. The PIDTC data should be submitted within the next couple months. Same thing with the comparison of our SCID data of all the donor sources. So hopefully you'll see those out there. Well, haplos are usually readily available for most pediatric patients. The delay immune reconstitution we see with haplos versus the early immune reconstitution we see with cords. I think this is so important to show this comparison. Oh, totally agree, Pavel, with you. I mean, I definitely see that often. It's very dependent on what type of platform you use with the haplos, right? There's a PT-Cy, alpha beta depletion, but I think what I have seen definitely still in the PT-Cy where you don't have that in vivo T cell depletion with the serotherapy, the cords without serotherapy reconstitute a lot faster. So I completely agree. How close to accrual in the Seattle study? John, this is for you. How close is the accrual to the Seattle study?
Yes, so that data I presented is that single center study is accrued. So we've accrued all our patients, and that will be coming to publication in the next 6 months. We have opened a subsequent clinical trial, so we've got another trial open, and that's the cord blood network one I discussed, where we've got multi-center involvement, and we're also looking to expand the amount of patients who are going to receive that regimen B.
Awesome. I think we got to the time here. It's been a delight to be doing this webinar with you all. Thank you, John, so much for sharing your amazing data. And please let us know if you have any questions. We're going to be sharing both of our emails if you have any further questions or you need anything else. We appreciate you all being here today, and I hope you have a great rest of your day. Thank you.
Thanks, everybody.